Brochard is my co-presenter, and we're going to talk to you a little bit today about recruitment. Now, I think most of you know the concept of recruitment, and what I am going to try to do is give the basics in the first 12 to 15 minutes, and then Laurent is going to take a slightly different tack and talk more about the technique. So, can we get started with my slides, please? That's it, okay. So, lung recruitment and recruitability, our approach. First, we're going to cover the basics. And when I say basics, and I mean something that I think all of you understand, but at the bedside is sometimes forgotten, that we measure pressure and volume at one point at the airway opening. And we have the same tidal volume delivered into patients who have a stiff chest wall, a normal chest wall, or active inspiration. And if we look to see what the volume is of the lung underneath it all, in those three circumstances, we have the same volume, the same tidal volume, but different recorded pressures. And since pressure and volume are very important to understand when you're talking about recruitment, you have to keep in mind that you really need to know the passive circumstances of the chest wall in order to get the accurate idea of what's happening inside the lung, right? So even if you have a normal chest wall and you have ARDS, one airway pressure is applied, but regional micromechanical forces differ. At the top of the lung, there's a higher transpulmonary force than there is at the base of the lung. And so you have recruitable parts and you have overdistending parts. And together, we need to try to balance that with one pressure at the airway opening. As I said, this is basic information that I think most of us understand. If you take someone and put them in a horizontal position, a prone position, then you're likely to get a more even balance of the transpulmonary pressures. And so your airway opening pressure will be more reflective of what's happening in each alveolus. Right? So if I have a certain pressure that I'm recording here, it corresponds to a transpulmonary pressure that is more or less the same top and bottom if I'm in the prone position, but quite different if I'm in the upright position. Point here is that position is very important in recruitment, and we take advantage of that all the time when we move patients from the horizontal to the upright position when they're supine, or if we go supine and go prone. We recruit different parts of the lung. Oh. Okay. So, if we look at the goals of recruitment, what are we trying to do? We're trying to enlarge the gas-filled part in ARDS we call the baby lung. To enlarge the baby lung of ARDS, we will improve gas exchange to raise the PaO2 to FiO2 ratio, increase oxygen delivery, improve CO2 elimination. We'll optimize the driving pressure associated with tidal volume for lung protection. We'll prevent, if we recruit, the opening and closure of alveolar units that are no longer collapsing and then reopening with each cycle. And a topic that I covered yesterday and will cover again on Friday, if we're thinking about power, the smaller the lung is, the more intense is a given assignment for that lung in terms of generating power. So the intensity of power is greater if your volume is smaller. If you can recruit lung tissue, then that will tend to reduce the power intensity that you're applying to the ventilator. And of course, you can reduce breathing effort in a spontaneously breathing subject if you recruit lung tissue. If we look at the relationship between the inflation percentage and the recruitment percentage, some people have only 5 or 10% of their lung recruitable in this blue line, but it follows a similar curve to the percentage of inflation of the lung itself. they're sigmoidal in their aspects. And Dr. Gattinoni's group, and I was an author on this paper, showed that in ARDS, they're very similar, those two curves. So that's just a basic piece of information. PEEP is instrumental to recruiting, not only recruiting, but stabilizing the recruited lung. And it will have effects on gas exchange, hemodynamics, and mechanics. And we'll talk about this in a moment. If we look at the benefits and consequences of raising PEEP in terms of gas exchange, we reopen a vascular bed. If we recruit, we get better P to F oxygenation, and that's a good thing. If we do not open the lung, we do not recruit, we will get overdistension of lung units that are already open and a redirected blood flow, and those things can increase stress and change the ventilation efficiency of the lung in a negative direction. This is good, this is bad. This is increased dead space, this is less dead space. PEEP has these effects on gas exchange. As you know, it has effects on hemodynamics as well, especially if we're looking at the afterload to the right ventricle or the reduction in the preload to the right ventricle. It has important effects in that way. So the cardiovascular effects of inflation with positive pressure are almost always there when we use PEEP. Now, this is a topic that is more topical, I guess, right now, is that if we look at strain and driving pressure, and we look what PEEP does to the relationship of the driving pressure to total airway pressure, as we recruit more, we also put lung units in jeopardy, the lung units that are already open, in more jeopardy of higher airway pressures, even if we're using the same driving pressure. We may have fewer lung units that are at maximal risk, but their risk is actually much higher than it was initially. So PEEP is not innocuous. It can cause gas exchange problems, it can cause mechanical problems. And I guess I'll just go over this very quickly. If this is tidal volume on the horizontal axis and this is pressure on the vertical axis, this being flow resistive, this being the dynamic elastic, and this being the PEEP-related parts of energy. When we look at the energy per cycle and multiply it by frequency, these days we call that power. It isn't really power, it's cumulative energy. But in each cycle, once we cross a certain pressure threshold, we're going to get into an unsafe zone of pushing more energy into that lung. This is a concept that has not got a lot of substantiation from the laboratory yet, but I think it makes perfect sense that we don't concentrate just on power, but also on the safe and unsafe part of what we're doing. If our threshold pressure for injury is high enough, then all of the energy is innocuous. If it's low enough, then all of the energy is dangerous. And in most lungs, you have parts that are safe and parts that are unsafe. I talked about that yesterday, and I don't want to belabor it, but just remember that PEEP always raises mean airway pressure. It increases global stress and strain. When I say global, I mean on average. It exposes new stress-focused interfaces. It increases delivered energy and power. It raises the risk of end-tidal hyperinflation and raises the back pressure to venous return. None of these things is a real good thing to happen. So you want to select the right level of PEEP and mean airway pressure and recruitment. This is an old theme. Didier Dreyfus and Georges Saumon from the Blue Journal back in 1994 asked the question, should the lung be rested or recruited? Because there are arguments on both sides. In most clinical circumstances, we're trying to balance gas exchange, hemodynamics, and mechanics, trying to do the best we can for our patients. So the answer is someplace in between, and I hope Laurent will be able to tell us a little bit more carefully how to set PEEP. I don't know how many of you have read this article. 1, 2, 5. 1975, Peter Suter, one of, I think, both of our friends. This is a paper which has its flaws, but it isn't a bad one. It was in the New England Journal of Medicine at a time when no one was actually concentrated on ventilator-induced lung injury. What he showed was that the best compliance, tidal compliance, had the least driving pressure, and more importantly, it maintained cardiac output and produced the least dead space. So the best PEEP for Peter was the lowest driving pressure associated with a given tidal volume. That isn't always true. It isn't true for all patients, but it's a good thing to keep in mind that if we look at mechanical parameters, we're likely to get a good answer. Sure.
Can we go back to the preceding slides? Oops, sorry. Yeah, just to be sure, we don't have oxygenation on this slide. What was really fascinating is that, so PEEP is increased, right, progressively. What do you think, this is the best PEEP. What do you think the PaO2 did after increasing the PEEP further? It went up. Okay? So the best PEEP is not the best PaO2. You continue to increase, and decreasing cardiac output is a mechanism to improve oxygenation. Very misleading.
Excellent point. Better oxygenation that you measure with a pulse oximeter isn't necessarily a good idea to follow the best PEEP to use, because it may mean that here's the cardiac output going down, PaO2 actually goes up because the shunt percentage goes down, PaO2 goes up, but who wants a lower cardiac output and an oxygenation which is more than satisfactory in terms of a PaO2? Very good point. Well, I'll stop here in just a second. This is another old paper. Old people remember old papers, and this was a good one. In the operating room, cats, I almost said cats in the Farrelly, took PEEP and went from 3 centimeters of water, which is very little, to 13 centimeters of water. That's 10 centimeters of water. The FRC change, which they measured, this is the total gas volume here, not tidal volume, and they found that about 10 breaths were necessary to recruit the lung with a tidal breath of the size that they were using. So it's a time-dependent process in a way. One of the French investigators who I respect a lot was Arnaud, and he concluded this, that you need about, in early onset ARDS patients, most of the recruitment occurs during the first 10 seconds of a sustained inflation recruitment maneuver. However, hemodynamic impairment is significant after the 10th second of recruitment maneuvers. In other words, you start to get a separation between these joint effects. You're recruiting more, but now you're in trouble in terms of cardiac output. In comparing sustained inflation with pressure-controlled ventilation, you can get to the same peak pressure, the same end expiratory pressure, and the same cumulative amount of stretch with a sustained inflation or pressure-controlled ventilation or a ventilating technique, and get a better result in terms of hemodynamics and gas exchange and other features if you use a ventilating type of. So the 40-40 second rule, I wouldn't use a sustained inflation for that. Okay, interrupted measures are better. Advantages: the same recruiting pressure, repeated maneuvers help with ventilation and lower mean airway pressure. And if you reach your target a little more slowly, at least in the laboratory, you find a little less damage in rodent lungs that are ventilated after a recruitment maneuver, that it goes to the same total pressure, but in steps rather than all of a sudden. Okay, so at the bedside, this is what you and I usually do, I think, and maybe Laurent will go further on this, but if you take a certain tidal volume and lift it in steps of PEEP up to a fairly high level and then drop it down following driving pressure, you're probably going to find a PEEP level which is acceptable in terms of oxygenation and poses the least stress for the cardiovascular system and on the mechanics. Last slide. This is a recent paper that Gatnoni and I wrote, saying that over the years, trying to find this best PEEP, the emphasis has gone in different directions. And now we're thinking more and more about assessing the lung in terms of its recruitability. And there's no one who's contributed more to that than my co-presenter, Laurent. And Laurent, I want to learn about recruitability in terms of overstretching and recruitment and making the best balance and choosing the PEEP.
Thank you so much. So maybe you can switch the two presentation. Yeah.
How can we explain the lower shunt when the cardiac output get lower?
That's an old question, right? So the shunt is the part of the cardiac output which goes into the non-aerated area. We don't have a good explanation. So the way I see it is that if you have more cardiac output, it kind of reopens the part which is vasoconstricted, because you have the hypoxic vasoconstriction. And therefore, you have a higher proportion of the cardiac output going into the shunt. So just to say, it's probably that, right? Because people looked at many different explanation. No, not a very good one. So that's the way I see it. But so I think you, as a clinician, you can think about that. So that's misleading, because you may increase your PEEP, decrease your cardiac output, and have better oxygenation because of that. At some point, you will decrease oxygenation because you will decrease the venous oxygen saturation, but initially you have a better oxygenation. So that's one of the reasons why oxygenation is not a good target for I'm not saying it's not associated at all with recruitment. Of course it is. But it is also very much influenced by hemodynamics, so that's a bit complicated.
Danek and Dansker wrote the paper back in the early 80s when a lot of physiology was being done, and that's what they found and confirmed.
And I think the title of the paper was something like decrease in cardiac output is the main reason for better oxygenation with PEEP, which I think it's a bit exaggerated, but made the point, right? So, okay, my point, and we can go on. Maybe maybe the question I'd like to ask to the audience is, do you think that any patient on a mechanical ventilator who has just been put on a mechanical ventilator, sedated and put in the bed, do you think all the patients need PEEP? Yes? No? Okay. Most critical care patients in your ICU, intubated, sedated, do you need PEEP? I think yes, in any patient, for two reasons. One is that in anesthesia, you take normal patients without any lung disease, you put them under sedation, paralysis, you lose 20 to 30% of lung volume, right? And we do that in all our patients. So I think you need some PEEP to counteract that. I'm not saying very high PEEP, but some level of PEEP. And second, the more atelectasis you have, the higher it is for the right ventricle to work. Okay, so for the right ventricle and for lung volume, I think you need some PEEP. However, 6, 8 centimeters of water may be okay. And the next question as a clinician is the rest of the lung recruitable, so I should try to increase the PEEP? That's my clinical question at the bedside, right? Should I put more than the 8 centimeters of water? And before addressing that and showing you a technique to do that, I'd like to be sure we talk of the same thing when we think of recruitment. And there are many ways to evaluate recruitment many definition. You have the CT scan, which is perfect, but very impossible to do at the bedside. And the way I see it is illustrated by, this is a cartoon coming from a very nice picture from the first edition of the Handbook of Physiology. I say first edition because it disappeared, and I'm very sad of that. But where you have, at the same time, a photograph of a lung, which is, so it's out of the chest, right? So John mentioned the role of the chest wall. Here you have no chest wall, but you see the lung at the very top is completely collapsed, right? And then you progressively inflate the lung until you reopen. This is great. You show on this one, I show on this one, okay? And you have at the same time, at the bottom, you have the pressure-volume relationship, you know? So you can directly look at the anatomy and the mechanics. And the pressure-volume curve tell you at the bottom that initially you have very, very little increase in volume while you increase the pressure. That's what you see on the top here. And once you've reached 20 centimeters of water, you go down on the deflation curve, and you see that for the same pressure in the system, you have much more lung volume. Okay? So this pressure volume loop in physiology, the fact that there is a big difference between inflation and deflation, it has been called the hysteresis. And part of this hysteresis is directly explained by the properties of the surfactant, which decrease the surface tension. But, as you can see on the photograph, it's also the reopening of the lung, right? So, the way I think of recruitment is something like that. It's you open the lung, you come back to a certain pressure, and for this same pressure, you now have much volume open, okay? So what we have tried to design is a technique which allows to tell if the lung of your patient is more on the recruitable side, so that would be a lung like that, or non-recruitable. And that would be very important, because if you conclude the lung is not recruitable, maybe you will be happy with your initial 8 centimeters of water of PEEP. Don't try to go higher. However, if the lung is recruitable, you can try to increase PEEP and see what are the effects on hemodynamics, oxygenation, etc. I'm not saying you will always go to 20 of PEEP. But. So, okay, I'm skipping that in interest of time. So, what we did is a very simple technique based on relatively simple consideration. We said if the lung is non-recruitable, it means that when you inflate the lung, you can exactly predict how much volume you will get for a certain pressure. Right, like a balloon. You know the elastance or the compliance of the balloon. For instance, you know it's 30 milliliter per centimeter of water, meaning that if you increase the pressure in the balloon by 10 centimeters of water, you should increase the volume by 300, right? 30 times 10. So we say, okay, if we can measure the change in volume between two PEEP levels, and compare to what is predicted by compliance, we can say whether this difference in volume is purely explained by the inflation of the lung, that would be no recruitment at all, or there is additional volume, which is the, let's say, a recruitment, right? Whether it's purely more units or it's a better mechanics of the lung does not matter too much for in this regard. It's you have recruited the lung. And the way we do it is we do a drop in PEEP. Why drop in PEEP? Because I think that de-recruitment is probably much quicker than recruitment. Recruitment, when you increase PEEP, it takes minutes, right? It's breath after breath. You reopen at the end of insufflation, you keep it open. De-recruitment is usually faster. So you see on the top, it's the pressure, the flow, and the volume. So the patient has been ventilated with a PEEP of 15 for a few minutes. Again, a few minutes because you wanted to see if the patient is recruitable. And then in one breath, so first we decrease the respiratory rate, and in one breath we drop the PEEP from 15 to 5. So this is a delta PEEP of 10. Okay, you could do with other measure, but that's where we have the most of the data. And when you reach a low PEEP, you just measure the compliance at low PEEP. And then the rest is based on what I told you. You calculate how much volume you expect if the compliance is the same with a delta PEEP of 10. And from that, you say it's purely inflation, no recruitment, or it's more than the volume which was expected, and it's recruitable. Okay, you will not remember what I've said today, but there is a web page called rtmaven.com where you have this video, you have the explanation, and you can come back. So I'm going to run this video, which is supposed to be preparing you for taking the data into a calculator, which is on this web page, so it's easier. So can we run the video? It should work. Oops, no. Do you have it? Okay, it's not a video. Okay, so. Okay. Anyway, if you go to the web page, you will see the video, and you can see the video with different techniques. So the video is just to show you in real time that in 1 minute you can do it. You decrease the respiratory rate, you drop the PEEP, you read the expired tidal volume, which should be the inspired plus the volume trapped by PEEP. And from this data and the plateau pressure at low PEEP to calculate compliance, you can calculate the index. That okay? Any question on that?
It's basically making the baby lung a little bigger.
Right.
If you're successful, the baby lung is bigger, the compliance is better, and if it doesn't happen, then you have an recruitable pressure.
Sorry, you have a delta peak, let's say at 10. Are you looking at the compliance at 50 or the compliance at 5?
We essentially looking at the compliance at 5, because this is where is the baby lung, as John said, and we want to know if this baby lung is simply inflated by the PEEP or it's recruited, which would mean that's a type of, I agree with you, John, but that's a type of compliance we are not used to measure because it's compliance based on delta PEEP, very complicated. We usually take the delta VT, right? So, and so from this, we calculate what we call the ratio of the compliance of the recruitable lung to the compliance of the baby lung. I'm not going to make the equation. It's not complicated, but to facilitate, that's why we have the calculator.
So if it's 1, it's not recruitable, and if it's more than 1, then it's recruitable?
If it's 0, it's not recruitable because it means you have no recruitable lung.
Minus?
Yeah, and it goes from 0 to 2.5, sometimes 3. And we consider that anything above 0.5, the lung is recruitable, more or less, right? The higher it is, the higher is the recruitability of the lung.
Then how do you use it to actually
Okay.
set the optimal?
So the question is, but how do you use it? So then, let me just show you very briefly. So we have kind of validation of the technique, which is difficult to validate. This is the way we validated initially. We said, well, in general, the higher the recruitment to inflation ratio, which you can see it's from 0 to 2 on this scale. The better is the oxygenation, the more you see a decrease in dead space, which for us was really an interesting concept. There have been studies showing that, it's reasonably well correlated with lung ultrasound. I think we need more data. So lung ultrasound is a very interesting technique, but it's much more time to do a complete lung ultrasound examination at 2 PEEP levels, but well correlated, and also recently correlated with EIT. And there is a recent study showing also a good correlation with CT scan. So I think it's not perfect, but it's a reasonable technique. And the next question, as you say, is how do you use it? So half of the patient, your R to I ratio will be 0.5 or lower. And then I say, stop, use the lowest PEEP possible, right? The lowest tolerable PEEP, which may be 8, 10 centimeters of water, depending on, but don't try to go higher because you will do more harm than benefit. I found this is a very important information first, right? So you will spare many. And remember, all the PEEP trials, they just randomized patients into 2 groups. One group was receiving high PEEP, all the patients, the other group low PEEP, no assessment of recruitability at all. So I think it would be very different doing a study like that. If the recruitment to inflation is high, I say, okay, it's worth trying to increase the PEEP. And the simplest way is to say, okay, increase the PEEP until you reach a plateau pressure limit, maybe 28, or look at your driving pressure, whether it goes up, etc. But and look at oxygenation, hemodynamics. So it doesn't mean that in every patient you will go to very high PEEP, but you know in this patient it's worth trying to see if it can be good to the patient. So it does not tell you the best PEEP level, but it tells you whether it's worth to try doing it, okay? And for instance, we have a simple algorithm saying we increase the PEEP until we reach a plateau of 28. Yes, Gustav?
When you use the expiratory tidal volume, will any mechanism of expiratory flow limitation, like tracheobronchomalacia, influence that?
Right, so that's a good point. And you will also see the video explain that you need to be sure there is no airway closure, which happen in some patients like tracheobronchomalacia, where in fact you decrease the PEEP, but the airway closed before you are at PEEP 5. And therefore, your calculation would be wrong because instead of going from 15 to 5, you may go only from 15 to 10. So in addition to that, you need to test whether the patient has airway closure. So that's important. The second thing is that before doing the drop in PEEP, we recommend for at least 2 breaths, drop the respiratory rate down to 5 so you don't have any intrinsic PEEP, which may, again, make the calculation misleading. Yeah, that's an important point. Yes?
And you spoke about observing driving pressure going up, potentially. So then you would use volume-controlled ventilation for these maneuvers.
Yeah, we use volume control. Most of the time when we do mechanics, we use volume control because it's much easier. It's simplified. Pressure control is great, but if you think of understanding mechanics with pressure control, it's much more complicated, in fact. So that's why we use volume control, not because it makes a difference for the patient. Yeah.
Do you also know if the recruitment to inflation ratio is higher in patients with a non-focal phenotype? In relation to a focal phenotype?
Great question. I think it's lower in patients with focal phenotypes. We don't have enough data, but that's my impression. Sorry?
You have lung ultrasounds in these patients.
Yeah, but that's the only data published so far. It's very few data. But my impression, yes, it's the focal will be less recruitable. However, there is a risk that there is always a risk that part of the lung is recruitable, part is not, and you don't know exactly the balance. So that's why I'm saying it gives you a direction, right? It's negative. I don't think you should go up. It's positive. You should try. It may be worse. No, it's here, sorry. Okay, how much time do we have? 0, okay? Any? rtmaven.com, so you will see the video. Okay?
But just remember, it's always a trade-off, okay? And so a higher recruitable index tells you it's more favorable or better than worse.
Maybe I can show this last one because to me it's eye-opening, as you say. This is an experimental study we did on, we wanted to test supine and prone, etc. And this is a PEEP, decremental PEEP trial, right, from 20 to 3 centimeters of water. Animal model of bilateral lung injury. And the curve on the top is the compliance of the respiratory system. So if you look at that, you say, PEEP of 16, okay, seems to be the optimal compliance, the optimal PEEP. But we also put EIT, which is the technique to visualize the different regions of the lung, and we say, let's look at the dependent part of the lung and the non-dependent part of the lung. You can calculate the regional compliance. What is the best regional compliance for the dependent part and the non-dependent part? Okay? And this is fascinating because for the dependent part, so, you know, the back of the lung where you see most of the atelectasis, you indeed need 16. But for the non-dependent part, you need only 8. Every time you go above 8, you start to hyperinflate the lung. So there is no way that there is an ideal PEEP for all the lung all the time, right? It's always a compromise. That's what John said. It's really a trade-off. So that's why I start by knowing whether it's worth trying to do something, but keeping in mind that even if my lung is recruitable, there will be parts of the lung which will be distended. And we still don't know what's the optimal balance between recruitment and distension. Okay, thank you very much.